Welcome to The Explainer. Today, we're diving into an absolutely incredible surgical procedure. We're talking about how surgeons literally build a brand new road for your blood to travel when the original one is completely blocked off, saving a limb from the very edge of amputation.
So just imagine this for a second. The main highway that carries blood and oxygen down to your leg, its absolute lifeline, suddenly hits a complete, permanent standstill. The flow just stops. The tissues start to starve. Now, this isn't just some hypothetical scenario. It's a real-deal medical emergency that puts the entire limb on a ticking clock. All right, here's our game plan. First, we're going to look at what it means for a limb to be on the brink. Then, we'll get into the fascinating process of planning the perfect reroute and actually building that new highway. After that, we'll explore how surgeons measure true success. And finally, what that long road to recovery really looks like.
Okay, let's start at the beginning. The limb on the brink. You know, this usually isn't something that happens overnight. It's a progressive condition that, when it hits its final stages, turns into a desperate race against time.
This traffic jam is caused by all that plaque, that gunk, building up inside the arteries over years. In the beginning, you might just feel some cramping when you walk. But when a major artery completely shuts down, it suddenly skyrockets from being a chronic issue to an acute, honest-to-goodness, limb-threatening emergency.
And this crisis point, it has a name. Chronic limb-threatening ischemia, or CLTI. At this stage, we're way past just having pain when you move around. This is the point where the lack of blood flow is so severe that the limb is literally, actively dying. Without a major intervention, amputation becomes a very real possibility.
And these are the big, flashing red lights. We're talking about pain that's there even when you're just sitting down, often worse at night. Sores or wounds that no matter what you do just refuse to heal because they aren't getting the blood they need. These are the unmistakable signs that a limb is in really deep trouble.
So, with a limb on the line, there is absolutely no room for error. Surgeons need a rock-solid plan. You should really think of it like surgical architecture. They're designing a brand new highway for blood flow, and every single detail has to be mapped out before they even think about making an incision.
The planning itself is this really comprehensive three-step dance. First, they have to check out the patient's overall health, right? Because the same disease blocking leg arteries is often in the heart too. Second, they create a super detailed roadmap of the arteries, the gold standard arteriography, to find the exact location of the blockage and, crucially, a healthy spot to land the bypass downstream. And third, they go looking for construction materials, using an ultrasound to map out the patient's own veins to find the perfect piece to build the new route.
And really, this is the heart of the whole plan. The conduit, that's the new pipe. The on-ramp is where they connected to a healthy artery above the blockage, and the off-ramp is where they connected to a healthy artery below it. Getting those three things absolutely perfect is the key to a bypass that's not just successful, but one that lasts.
All right, the blueprint is done, we're in the operating room, and right now, the single most critical decision the surgeon has to make is about the building material. What are we going to use to build this new arterial highway?
And the choice pretty much boils down to this: natural versus man-made. The absolute gold standard is using a vein from the patient's own body, usually the long saphenous vein from the leg. And why is that? Well, because it's living tissue. Its inside lining is naturally slick and resistant to clots. The alternative, a synthetic tube, is basically a foreign object, and it's just way more likely to get clogged up over time.
And here, right here, is why that choice is so incredibly important. This chart shows us patency, basically the percentage of bypasses that are still open and working after 5 years. Look at this. For a natural vein graft below the knee, almost half are still flowing freely. For the synthetic ones, only 12%. I mean, that is a massive difference in durability. Nature just builds a better road, period.
This quote from the research, it just says it all, doesn't it? The success of the entire operation really comes down to the quality of that conduit. Yeah, you need a skilled surgeon, no doubt. But the building material, that is everything.
So, the new highway is built, blood is flowing again. Awesome. But what does success actually look like? Because it's about so much more than just a technically perfect surgery. It's about durable, long-term results for both the limb and, the patient.
So the first way we measure success is this technical term, graft patency. It's a pretty simple idea. Is the new highway still open for business? Is traffic flowing?
Surgeons track this to see if the graft has ever had an issue or if it needed a little tune-up to keep it from closing down completely.
But, patency is just a means to an end. This number, this is the real goal. For bypasses that go deep into the calf, using the patient's own vein, the limb salvage rate after 4 years is a stunning 82%. So this procedure, it doesn't just work, it saves limbs for the long haul.
And this, well, this is where it gets really profound. Data from a huge landmark study found that for patients who lived at least 2 years after their procedure, getting a durable bypass wasn't just linked to saving their limb, it was linked to them living longer, period. So in a very real way, saving the limb is connected to saving the patient's life.
But look, a successful operation is not the finish line, not even close. That new bypass is an incredibly precious investment, and protecting it means a lifelong commitment to maintenance and surveillance.
So after the patient heads home, their life with this new vein graft involves a very structured checkup schedule. Using ultrasound, doctors scan the entire length of the new bypass, first at 1 month, then every 3 months for a while, then every 6, and eventually once a year for life.
And this is not just some routine follow-up, it's proactive preventative maintenance. Because even that natural vein graft can start to develop new narrow spots over time. The best way to think about it is like a road inspection crew looking for potholes. You find and fix a small problem early, before it can cause a massive traffic jam and shut the whole highway down. That's what keeps the limbs safe for years to come.
And that really brings us to our final thought, a question that's right at the heart of modern vascular medicine. On one hand, you've got this incredibly durable, life-altering surgical solution. But on the other hand, you've got these newer, less invasive techniques, with balloons and stents. They're definitely easier on the patient in the short term, but they're often less permanent. And the challenge for doctors and patients today is always choosing the right path. How do you balance the proven long-term durability of surgery against the appeal of a quicker, but maybe shorter-term fix?